Now, I'll ask the first speaker to introduce.
Good afternoon. Today we have very important topics. I felt the postgraduates and the undergraduates this year situation should have been here to learn very important aspects on general practice and how to interpretation in the lab diagnosis. Today we have the first speaker, Dr. Sudha senior physician in Chennai City, has been in the field of internal medicine and preventive healthcare for more than 20 years. She has worked as a consultant physician in several healthcare hospitals, including HM Hospital and Hospital Diagnostics, and currently practices at Canada Health Alliance, Mylapore, and Bihar Clinic, Nandanam. Dr. Sudha has obtained her MBBS from Helpline Medical College in 1991 and received Diplomy in General Medicine in 1999 from Helpline Medical College, and has worked also in Government Rapid Hospital, Chennai. She is a life member of the Association of Physicians and the Indian Medical Association, known for her strong relationship with her patients. Dr. Sudha is passionate about community interaction to increase awareness about healthcare, and today she is here to talk on simple interpretation of common lab reports in family practice. Welcome, madam.
Thank you, sir. Thank you very much for the kind introduction. Good afternoon, everyone. At the outset, I would like to thank the Indian Medical Practitioners Association and the IMA Chennai Metro Venkataeswara for giving me the opportunity to discuss this interesting topic this afternoon. Now, all of us are not going to test our patients immediately when they come to us for any small ailments. Usually, we are going to start treating them with some medication, and then we will decide if they are not recovering, we are going to test the patient. So when do we choose to test the patient? We choose to test only if the results will influence the treatment, and we should also interpret the lab results keeping the clinical picture in mind. If there is a disparity between both, please trust the clinical judgment and maybe even repeat the test before acting solely on the basis of the numbers. So while interpreting the reports, the numbers we base our decisions on are given as a normal range or reference interval, which includes 95% of the patient population. What are the common tests we prescribe? We start with hematology, most frequently the CBC or the complete blood count. So when will we ask for the CBC? Currently, since many of us have been seeing fevers and influenza-like illnesses over the last few months, in fact on and off over the last few years, we'll be wanting the counts to give us a clearer idea of what we're dealing with. If when we're given symptomatic medication, the patient is not responding. So how do we interpret the CBC? We discuss the white cell count first, as we are talking about the fevers. The normal total leukocyte counts range between 4,000 and 11,000 cells per microliter. General thumb rule, higher counts over 11,000 cells direct us towards a bacterial infection, lower counts towards a viral infection. But when the counts are high, we need to also consider normal individual variations, conditions such as pregnancy, where the counts can be as high as 18 to 19,000 cells per microliter as the body adjusts to the baby. Total counts can also increase with anxiety or stress, with other inflammatory disorders, and with malignancies. To get further clarity, we need to look at the differential count next. Here, when we are looking at the differential count, please remember absolute values are more meaningful than the percentages. The neutrophil counts generally range between 2,000 to 7,500 cells per microliter. So that is about 40 to 75% of the total count. And again, these are increased in bacterial infections as a rule. Other inflammatory disorders, steroid use. When patients are on steroids, if you have a neutrophilic leukocytosis, sometimes we get in a dilemma because is the finding due to the steroid use or is there a superimposed bacterial infection, especially if they have a fever or a cough. Again, we have to decide based on the clinical picture. Then stress such as trauma, burns, surgery, hemorrhage, all these can cause the neutrophils to increase along with the leukocytes. I talked about leukocytosis with stress, but that sort of anxiety and stress won't cause an increase in the neutrophil count. Generally, the ratios are normal. Then the neutrophil counts are reduced in viral infections as a rule, and you have the total counts also reduced then. Other conditions, bone marrow failure, drugs, post-chemotherapy, hypersplenism due to destruction, SLE, anemias. The one difference, bacterial sepsis can cause a severe reduction in the neutrophil count, unlike other bacterial infections. So this is just one exception to the rule, where bacterial infections are going to cause increase in the neutrophil count. Next. Now we go on to the lymphocyte counts. This range again is between 1500 to 4500 cells per microliter. That is about 20 to 45% of the total count. Lymphocytes again generally increase in acute viral infections. Of course, chronic infections in our country such as TB, hepatitis, and the malignancies, leukemias, lymphomas with abnormal cells. And the counts are reduced with steroid therapy, uremia, and autoimmune disorders like SLE, and HIV, of course, where you have the atypical CD40 lymphocyte counts. But however, when we're talking about these counts being reduced, lymphocytes reduced in acute viral infection, and the neutrophils the counts being high during viral infection, we find during COVID we have found, especially in the Delta wave, that there's a marked lymphopenia. So this used to differentiate it from the other viral fevers when we saw that. And sometimes the total counts were also high then. And if lymphopenia persists, very often we find that it is seeming to be a finding of long COVID, a persistent lymphopenia. If the patient has recovered well from a COVID infection, the lymphocyte counts are often higher. So in our practice, very often you find lymphocyte counts over 40-45% with normal counts. Then we can just reassure the patient this is probably post-COVID and the immunity is pretty good. Go on to the eosinophil counts. The eosinophil counts range between 40 to 400 cells per microliter, about 1 to 6% of the total count. Of course, these are increased when you find eosinophilia, increased in allergies, asthma, atropies, like Dr. Kailash will be very familiar. And it is also very often associated with very high IgE also in these patients. And it's better to check the absolute eosinophil count rather than just working on the percentage of the total count. If your absolute eosinophil count is over 500, then you may want to take it further and treat the problem. And it causes parasitic infections, drug reactions, skin diseases, and the convalescent phase of any infection. Again, the eosinophil count reduction we saw during COVID again. There was sometimes, 0.1% eosinophils, the counts were very low. Also in enteric fever, it is very typical, you may find 0 eosinophils in such patients. Monocyte and basophil counts, we don't really see too much of variation in those. But monocytosis, a higher monocyte count, we have to think of chronic infections and malignancies. And the basophil counts range between 0 to 100 cells, again in inflammatory disorders, myeloproliferative disorders, etc. So I think we've completed a reasonably comprehensive overview of the lymphocyte count. Next. Now we just move on to the hemoglobin concentration and the erythrocyte or RBC picture. So what is anemia? It's a low hemoglobin concentration, less than 13.5 gram per deciliter for men, less than 11.5 gram per deciliter for women. When we see a low hemoglobin percent, what are we going to do next? We can't directly give them the iron supplement. It is better to check the mean corpuscular volume, the mean cell volume, before we decide in which direction we are going to treat. And besides assessing the MCV, we also need to assess the cause and try to treat. So once we look at the MCV, if there's a low MCV, that is a microcytic anemia, again the most common cause is that iron deficiency anemia. And with iron deficiency anemia, it's safer for us to look at the causes. It could be a bleed, it could be due to iron deficiencies, hookworm infections. If we don't know the cause, we don't treat the cause, there's no point just giving the iron supplementation. Your hemoglobin is not going to increase. It's like filling a leaky bucket. You have other causes of microcytic picture. like anemia of chronic disease, renal failure, autoimmune disorders. Then in thalassemia, sideroblastic anemias, lead poisoning. See, we're all not going to test for all these once we see a microcytic anemia. If it's a hypochromic microcytic picture, we'll start, check the cause, treat for iron deficiency anemia. If that is not clearing up, if you're not finding an increase in the hemoglobin or reticulocyte count, then we can go further to test for the other causes. So the other cause tests we will do after that is the iron stores, the ferritin, the TIBC, and in iron deficiency anemia, these will be low, whereas in the other conditions, the differentiation will be iron stores will be high. Next please. Then we will move on to the normocytic anemias with normal NCV. Acute blood loss, you know with the clinical picture. Anemia of chronic disease, that is one condition we find commonly. A person with a chronic kidney failure or with vasculitis, rheumatoid arthritis, with malignancies. In all this, you have a normocytic anemia. Your iron supplementation may not work in such patients. For CKD, you may even want to give erythropoietin instead. In pregnancy also, you may find a normocytic anemia, but this is more because of increased plasma volume. It is a relative iron deficiency, not a specific deficiency. Other conditions like bone marrow failure, where your other cell lines will also be reduced. Hyperthyroidism, in this you can find normocytic anemia. And hemolysis, all these, the clinical picture will help us. And the further test for the diagnosis which you want to do again is your iron studies, smear studies, inflammatory markers, liver, kidney function, thyroid function, etc. We move on to the macrocytic anemia. Most common cause again, we are thinking about B12 or folate deficiency. And in this condition, in the peripheral sphere, you will see megaloblasts. Other causes of macrocytic anemia, we are unlikely to see a megaloblastic picture. So when you see the megaloblastic picture, again you check the diet, check for antifolate medication history. So phenytoin, methotrexate, because very often we need to remember the drugs importantly. What of our medicines can cause the anemia and try to see whether they are required or not. Other causes of macrocytic anemia, alcohol excess or liver disease, where the GGTP will be markedly elevated. Dr. Kailash didn't want me to talk about the GGTP, I decided to mention it there. And hypothyroidism, hemolysis, myelodysplasias, all these, the clinical picture, and further testing like the history, the smear studies, your B12 folate levels if required, LFT, thyroid function, and of course bone marrow studies if needed. However, as practicing family physicians, to sum up, I think we just check the hemoglobin first. If the hemoglobin is low, look at the MCV. If MCV is low, most common cause, iron deficiency anemia, treat the anemia and the cause. If the normocytic anemia, most common again, anemia of chronic disease, then we check out for thyroid, for renal failure and for autoimmune diseases and treat as required. If you have a macrocytic anemia, megaloblastic anemia is the most common, supplement the B12 and folate levels. Next please. While we are discussing the RBCs, we will just mention polycythemia. A hemoglobin of over 18.5 gram per deciliter in men, more than 16.5 gram per deciliter in women, or a PCV, the hematocrit, more than 52% in men and 48% in women, is a result of polycythemia. Now you have relative polycythemia, could be acute and due to dehydration, and more common as with obesity, hypertension, high alcohol, tobacco intake. Absolute polycythemia, primary of course polycythemia rubra vera, but secondary we should remember when you see a polycythemia, you think of a high altitude, importantly in our patients, chronic lung disease or smoking. These are the conditions which we would like to think about. Others of course, other conditions we can check according to the clinical picture. Next please. We conclude the CBC discussion with a few points about the platelet counts. This range is between 1.5 to 4 lakhs per microliter. A thrombocytopenia we are seeing very commonly with the fevers nowadays, most commonly with dengue fever, where you have it with the leukopenia also. And this usually is seen in the third or fourth day of the fever, once the fever is subsiding a bit, and then you have a rash and then we check for the counts. Just keep an high on the counts, usually we give supplements. We're giving this Caripil and folate supplements also. If the counts are not increasing, if there's a rapid reduction below 40,000, if we are going to find that there's signs of bleed, then it would be required hospitalization. Unless we can treat and the counts bounce back very well within a week. Other causes, of course, reduced marrow production, excess destruction, we ignore that. Thrombocytosis, the platelet count more than 4.5 lakh per microliter. It may be a reactive phenomenon with many conditions, including stress, trauma, surgery, bleeding, etc. Again, in our clinics, when we see patients with counts around like 5 to 6 lakhs and we have no other symptoms, very often it is just stress and anxiety related. So we don't need to really push it further, just monitor and see how it's going. Of course, if they are very high, then the coagulopathy is going to be a problem. So if it's persistent, we'll have to investigate it further. We just briefly discussed the ESR, the erythrocyte sedimentation rate. It's a sensitive but non-specific indicator of any inflammatory problem. Normal range, less than 20 millimeters per hour. The main causes of raised ESR, of course, any inflammation, infections, and here we're always going to think about TB. Then autoimmune disorders, rheumatoid arthritis and other connective tissue diseases. Malignancies such as leukemia, lymphoma, in MI, and importantly, please remember in anemia. In anemia, the ESR is likely to be high. As the hemoglobin reduces, the ESR is going to be higher, so we don't have to worry about it, just correct the anemia. Now post-fever, we are very often seeing higher levels. The patient has a polyarthralgia and we find this borderline elevations of the ESR, and now the CRP is also being done then. If they're not really very high, 45, 60, 80 range, we can choose to wait, maybe retest after a month. Of course, ESR levels above 100, then they're definitely significant and it is better that we test for the above causes. The ESR also increases with age. So we calculate the upper limit of normal using the Westergren method. So for men, it's age in years divided by 2. Women, age in years plus 10 divided by 2. As we've discussed the CBC and the ESR, and we're talking about fever, very often we have patients presenting to us on second day, third day of fevers. They'd have got the lab themselves. They'd have come with a fever profile package test. So this test is actually very unnecessary. You know, they're performing it on day 1 or day 2 of a fever. None of the tests are going to be contributory to our diagnosis at all. The CBC, of course, we've already discussed. This may be the one thing which is helpful, at least we know bacterial or viral. ESR, again, we've talked about, and CRP is commonly raised along with the ESR. Again, we just say it's an inflammation sign and we leave it. Smear studies for MPMF will have mostly negative because it will not have been done during the rigor. Of course, QBC is more easier now, that's what's done commonly. They come with a viral test on day 2 of a fever. And it will be non-specifically elevated, madam, I have typhoid. So we have to tell them, see, first of all, the viral test, I don't know why we still do it anyway. It's absolutely non-contributory. Rising titers in second week of fever, maybe it's going to help us. We're going to diagnose with the blood culture. But the labs offer these packages, and then the patient needs a lot of convincing that they don't have typhoid. Again, the dengue, all the 3 tests will be done on the same day. NS1 antigen, IgM, IgG. Again, the IgG will be positive. The patient will come with this and say, I have dengue. Then you have to convince them, no, you don't have it. You've had it sometime in the past. This is some other reason. Please wait and watch. I'm sure many of us have seen these packages, you know, and really to convince the patient takes a lot of effort because they have to Google the symptoms of dengue, they have Google the symptoms of typhoid, they can convince they have it. It's just they come to us for a prescription, they will even know what drugs they need to have. That's how it's going nowadays. Next slide, please. Right. We then go on to the biochemical tests, right? We'll start with the blood sugars. So out of the 4 types of diabetes mellitus in the current classification, in outpatient practice, we are going to see type 2 diabetes and gestational diabetes commonly in adult practice. Of course, in pediatric practice, type 1 you might see. So when do we diagnose diabetes mellitus? In symptomatic non-pregnant individuals, fasting plasma glucose above 126 or a 2-hour post 75-gram plasma glucose test of over 200, or any random plasma glucose test of over 200. This confirms your diagnosis of diabetes. So when do we do the glucose tolerance test though? The glucose tolerance test we do if the people are asymptomatic, above 40, sedentary lifestyle, family history of diabetes, or with impaired fasting blood glucose, or with random values between 100 and 200. Then we do the oral glucose tolerance test. And this is usually done with 75 grams of glucose in 150 to 300 ml water. Interpretation of the test, of course, impaired fasting glucose is before the test, 100 to 125. Impaired glucose tolerance, 2 hours post glucose value, 140 to 199 milligram per deciliter. Gestational diabetes mellitus. Screening for GDM in India is done at the first antenatal visit because we are high risk category in India, and is done with 50 gram glucose load. And the fasting sugar of more than 95, 1 hour value more than 140, they have to be retested at 24 to 28 weeks with a 75 gram glucose load. There again, 1 hour value more than 180, 2 hour value over 155, requires diet care, exercise, and then you keep re-screening every 6 weeks. So a GDM you will say at lower levels than a diabetic person who is not pregnant. Values over 180 you consider as a gestational diabetes. Next please. We'll go on to the monitoring of the control of the diabetes. Besides monitoring the fasting and the PP blood glucose, we do the HbA1c that monitors control over 8 to 12 weeks, which is about the half-life of the RBC. And the normal values are 5.6%, below between 5.7 and 6.4 pre-diabetic, over 6.5% fall in the diabetic range. If we maintain it, ideally maintain the sugars less than 7.5% because values over 7.5% increase the risk of chronic complications. If the values of the sugars and the HbA1c do not correlate, sometimes we find that fasting BP sugars will be in normal range, A1C will be high or vice versa, then check the hemoglobin also. A low hemoglobin can very often alter the HbA1c or elevate the HbA1c. So that is again something we should keep on mind, and we cannot base the treatment on a single number. Fructosamine we don't often test in general practice. If you want to check the short-term control like in pregnant women or in hemoglobinopathies, you may want to test the fructosamine. And again, when we talk about lab tests for early detection of chronic complications, the screening for microalbuminuria that we can do. Microalbuminuria is the albumin excretion rate of 30 to 300 milligram per day. And once we detect this range, we have to intervene for tighter glycemic control, stricter control of hypertension, and your other risk factors also. The complications, I don't think we're not going to see too much of DKAs and the hyperosmolarcomas in family practice. Of course, if there's some altered sensorium, patients are confused and the sugars are very high, you can test the urine ketones, urea creatinine, electrolytes. Diagnostic, anyway these patients are going to be admitted, so we're not really treating them as outpatients then. Hypoglycemia, an absolute value less than 50 milligram per deciliter, or if you have a relatively low plasma glucose concentration with signs and symptoms of autonomic hyperactivity, severe sweating, palpitations, and neuroglycopenia, blurred vision, confusion and all that, then you check the sugars and treat accordingly. Now again, your diabetes package sometimes offers you an insulin test also sometimes. So if your fasting insulin is high with normal sugar values, we should consider insulin resistance and pre-diabetes and make sure we are screening the patient on a regular basis. We move on to the renal profile. This the BUN normal range 6 to 24, creatinine 0.6 to 1.2 milligram per deciliter. Few points to notice here. The urea and creatinine levels are elevated generally only after more than 50% of renal function is lost, because with a single kidney, a patient can maintain the normal urea and creatinine levels. So already when the levels are rising, you know more than 50% of kidney function is lost. Secondly, the creatinine elevation is more significant than the urea elevation, because physiological variations are high with the urea elevation. For example, if dehydration or the protein intake is increased or there's catabolism with fevers, urea will be raised, creatinine will be normal in those stages. And we also see patients who say they have a kidney problem when they find that the urea and creatinine are low. Now, low levels usually indicate that lack of muscle strength or reduced protein intake. We can reassure them that the renal function is normal, but they need to increase their protein intake and they need to do some strength training exercises. And the urea and creatinine levels also reduce with aging. So actually in elderly patients, if we see levels of 1.2, 1.4, it means the levels are actually higher because their loss of muscle mass, their creatinine should be on the lower side. Uric acid, normal range 3.5 to 7.2 milligram. Besides the usual causes of hyperuricemia, like increased turnover, leukemias, lymphomas, reduced excretion, of course, like in kidney failure and all that, we need to remember the medication the patients are on. Some drugs can cause high uric acid, especially our antihypertensive. So thiazides, ARBs such as olmesartan, these can cause a rise in uric acid. So if you're choosing an ARB and uric acid tends to be high, it's safer to go to losartan, where in fact it can cause a reduction in the uric acid. Telmisartan is uric acid neutral, so you can choose accordingly. We go on to the electrolytes. Sodium, the normal range, 135 to 145. Potassium, 3.5 to 5. The other two change accordingly. Now, hyponatremia is something we see very commonly in elderly individuals with all these comorbidities, hypertension, diabetes, etc. And it's best not to directly treat them with a salt load because dehydration may be one of the causes, but very often they are hyponatremic relatively due to a fluid overload. So the assessment of that is important. So they all say, oh, uppu kammiya irukku, uppu saaprom sonanga. The fluid retention will be higher and the problem will worsen. So that is a consideration. Again, medication here, AC inhibitors, thiazide diuretics, antidepressants, these also we need to think of when we're seeing lower sodium levels. Potassium changes, okay, the clinical picture, vomiting, diarrhea, etc. Think of your diuretics and your laxatives causing a low potassium. If the potassium levels are high, most common cause renal failure. Again, think of the drugs, you know, AC inhibitors, ARBs, beta blockers. So we may want to change the medication in case you are detecting a higher potassium. So the BP medication in connection with the uric acid and electrolytes is what I want to emphasize here. We choose our medication based on these values too. And so please continue to monitor the electrolytes when we are giving medicines like ARBs and ACEIs. At least once a year, make sure the electrolytes are monitored. And another condition where the potassium can be high, we are finding no reasons for it. Spurious hyperkalemia. There may have been a cell lysis while withdrawing or a long transit time, then we may want to repeat the potassium value. Okay, calcium, phosphorus, vitamin D, there's a lot to discuss with this. In kidney failure, generally your calcium levels are low, phosphate levels are high, but depending on secondary hyperparathyroidism and all these can alter. Usually the serum calcium is maintained well at the expense of the bone. So it may be normal in these conditions also. But if we have hypocalcemia and you're treating with calcium supplements, here I'm not talking with renal failure. Generally it's a hypocalcemia and a vitamin deficiency. Hello? Yeah, it's fine. Hello? If you're having hypocalcemia, vitamin D deficiency, you're treating the patients with calcium and the vitamin D supplement, still calcium levels are not going up. Please remember serum magnesium. We don't test this regularly, but with a magnesium deficiency, your calcium correction may not be there. So check the magnesium and supplement that too additionally. Complete urine analysis, again we do hematuria, pyuria, etc. In all these, one thing, please remember, it may not be only a urinary infection. In men, it could be due to prostate problems. Secondly, the patients sometimes check the urine sugars and say they're very high, do I have a problem? Urine sugars are not required for monitoring. In fact, should not be done for monitoring of diabetes because two things. One, you could have a renal glycosuria. Secondly, your drugs like your SGLT2 inhibitors, EMPA and DAPA patients are on such medication. Their sugars are going to be 3+, 4+ in the urine. So we just need to reassure them that the high urine sugar does not mean that their sugars are not under control. Let's see. We'll move on to the liver profile. The bilirubin total range, indirect, direct ranges are given. Liver enzymes, the ranges are given there. So when we're just talking about jaundice, we have that's when serum bilirubin is over 3 milligram per deciliter. In a jaundice patient, we can broadly divide into 3 subgroups. One is bilirubin will be increased with normal enzymes. In this case, it's generally pre-hepatic and you want to check for your hemolytic anemias, etc. Or you have the congenital hyperbilirubinemias. Indirect bilirubin higher and direct bilirubin higher. If your enzymes are normal and the bilirubin is 2, 3, etc., just monitor, need not do anything beyond that. If the bilirubin is elevated and predominantly your AST, ALT, GGDP are elevated, it's mostly a hepatocellular jaundice. Think of your viral hepatitis, drugs, etc. Third, if the bilirubin is elevated, alkaline phosphatase is high, then it's the obstructive picture, post-hepatic picture. So we discuss, we divide based on this and we do your imaging studies in that case. If only your enzymes are elevated, if only the AST, ALT, GGDP are elevated with normal serum bilirubin, then early fatty liver, drugs, alcohol. So again tell the patient, correct the cause. If only alkaline phosphatase is elevated with the normal liver enzymes, then we consider non-hepatic causes. Most commonly it is due to the bone, very often due to vitamin D deficiency, hyperparathyroidism, Paget's disease, and all these, alkaline phosphatase will be elevated, all your other liver enzymes and your bilirubin will be normal. If alkaline phosphatase is low, then sometimes it's a vitamin deficiency, just a zinc deficiency be correct, that's going to be okay. We'll go on to the short discussion of the lipid profile. The main 3 parameters which are measured, the total cholesterol, the triglyceride and the HDL cholesterol, the values are given there. The others are calculated from these 3 levels. And for cardiovascular risk, the assessment we do is the LDL cholesterol. It's required to be less than 130 milligram per deciliter. So with other risk factors, you may want to treat. Cardiologists now are saying it should be less than 70. I don't know how many of us as family physicians are following that. Anyway, that is going to be post-intervention, so they will have to take care of that. And importantly, do we require fasting levels to test the lipid profile? Or are random measurements okay? Because sometimes patients walk in, we tell them to do tests, they may not come back. So if we get them to have the test done, and it will be easier. So cholesterol values, a random blood test is equally alright. But to assess for triglyceride, this is based on the carbohydrate metabolism. For hypertriglyceridemia, a fasting level is much more accurate. Also importantly, if the patient is on statins, we need to monitor the liver enzymes. SGPT can go up because of that. And the CPK, they will come to us with body pains. So we can test the CPK for the myalgias, which is as a side effect of this. Then finally, just the other test which we do on the regular package actually. The package, we don't ask for all the tests. But the patient will come with a package of tests. You get about 12 pages or 24 pages of all these tests, and they'll find small numbers off, and we'll have to explain the whole lot to them. The thyroid profile, of course. For screening, the TSH alone should be sufficient. If the TSH is normal, we don't have to do anything else. If the TSH is elevated, suggestive of hypothyroidism, we do need to test only the free T4. If both are high, hypothyroidism. If TSH high, free T4 normal, because we see all these pictures. Then we think of subclinical hypothyroidism, treat based on the clinical picture or monitor. If the TSH is low, we need to check the free T3. For hyperthyroidism, we need to test this. This is what we need to test. Thyroid antibodies, of course, we're not going to test unless there are other autoimmune disease symptoms, or if you have a nodule or anything, you may want to test for Hashimoto's or Graves' disease. PSA, again, the test will come as a routine screening. It is advised in men between the ages of 55 to 69 years. Normal values less than 4 nanogram. Between 4 and 10, we can wait and see. If it's and monitor maybe once in 6 months or so. Rapidly rising above 10, of course, please refer to a urologist. Vitamin D, I've already talked about the calcium and vitamin D which comes in our package. Vitamin B12, this is the normal range. We've all seen ranges of 3,000, 4,000 in vitamin B12 also. Because any patient who comes to us, numbness, tingling, weakness, we give them neurobiology, something or the other. So then we have to tell them, okay, this is a drug-induced thing, we stop and we can recheck after 6 months or so. There are so many more things which come in the packages, right? People come up with apoproteins, this, that. In fact, I had a patient coming with mineral assessment, including arsenic, lead, beryllium, all these tests. I don't think we need to discuss any of these. We just have to reassure and say, we didn't even ask for the test. We don't need to interpret them, but for your sake, we are reassuring you. Please don't have the tests at all. But surprisingly, I had a patient, 83-year-old, the package showed prolactin value of over 250 milligram. And see, when we are giving them this Sontra, Spandy and all, any of these, prolactin goes up, but not to these values. And since she was traveling abroad, did an MRI, there's a pituitary microadenoma there. We would have never done the test because at 83, she was absolutely asymptomatic. Prolactin we are checking in our younger patients only, people who have irregular or delayed cycles or other problems. So that took me by surprise though. Sometimes these packages just pull out some weird things which are there. Right? Next please. So thank you very much. I again thank Dr. Kailash and Impai and IMA. Thank you all for your patient hearing. Yes,
Any questions?
If the total count is increased,
yes.
Can it be due to when steroids are being given?
Yeah, I have mentioned that.
Yeah.
Steroid use, the total count is increased. Neutrophils also can be increased in those patients.
So total count can go up to
Because of steroids.
14,000.
Yes, very much so. 14, 15, we've seen even as high as 18,000. So we don't know, sometimes we'll be thinking, because the patient will come to you with a cough. And you don't know whether to treat or not. These post-viral coughs are now lasting. We're all saying 6 weeks, 8 weeks, 2-3 months they have the cough. So definitely it can go up with steroids.
What level of triglycerides can cause pancreatic inflammation? They say high levels can cause
Okay. We are not, see, over 300 we are supposed to treat, no? And beyond 300, beyond 500 probably, I've seen patients with even 800 and 1000
Is it common
levels.
to see pancreatic inflammation with triglycerides?
I have not seen any. I've seen with uncontrolled diabetes, when we check for pancreatitis, then we found that, but I haven't found that the triglyceride alone does. About 300 I treat, madam.
Quite scary.
I actually treat rather than the statin or fenofibrate. If the person is diabetic and has fatty liver and the triglycerides are very high, cholesterol are all right, then I prefer to choose saroglitazar. It works very well and they don't have the side effect of myalgias. Whereas in the statins, many women are unable to tolerate statins with the acid peptic disease and myalgias, whereas they tolerate saroglitazar very well. Cost is high. So,
Is oral intake of flaxseed or hot liver oil, does it really help?
It's supposed to help with increasing the HDL. But again, whether you can tolerate, the flaxseed dose is supposed to be 1 tablespoon twice daily. And that is quite intolerable, it causes severe bloating and flatulence. So we're adding 3 or 4 doesn't make a difference. Easier for us to tell them, increase your almonds, walnuts, they find that much easier.
They say what comes out of that is very less compared to the fish oil.
I think end of the day, the exercise is very important. However much you supplement this omega-3, we can give them omega-3 supplements also. Even the vegetarian forms of omega-3 are available. We can give them that, but if you don't exercise, the HDL doesn't go up. Okay. Thank you.
Thank you very much, madam, for elaborate in the list of the investigations in general practice. On behalf of Helpline, I am giving a mark of laptop.
Thank you.